Good afternoon, everyone. I think we're going to go ahead and start. I want to welcome you to the seminar, which is sponsored by the RTI Fellows. For those of you who don't know me, my name is Paul Beamer. I'm a distinguished fellow at RTI, and it's my honor to introduce our two speakers this afternoon. Today's talk is titled, Where's the SES in Stress? Building on AdHealth to Improve Our Understanding of Health Disparities Among Sexual and Gender Minorities. So this study is related to the Sexual Minorities Ancillary study that UNC is conducting with RTI as the data collection contractor. The study builds on data from the previous waves of AdHealth survey, whose data that RTI is also collecting for the UNC Carolina Population Center. And the ancillary study focuses on socioeconomic status and health and how these are related to one's sexual orientation. And I think it's a fascinating study, and I'm very pleased to be a part of that project team. So our presenters are Doctors Carolyn Halpern and Conron, both of whom have very impressive credentials and are world-renowned experts in their respective fields. Dr. Halpern is professor and chair of the Maternal and Child Health Department at UNC and is a co-director and co-investigator of the AdHealth survey. To say she's an expert on adolescent and young adult sexuality is an understatement. Certainly, she's one of the foremost experts in the field with more than 100 publications to show for it. And we are truly honored to have her here today. Likewise, we are very proud to present Dr. Conron, who will be live streamed from the UCLA School of Law, where she holds the position of Blackford Cooper Research Director and Distinguished Scholar. She is a Harvard-educated social and psychiatric epidemiologist whose work focuses on documenting and reducing health inequities that impact LGBTQ populations. She is and has been a co-PI of several studies in this area and has been active in the LGBT health for more than 15 years. So please join me in welcoming our speakers. We're very excited to have you both here today. Thank you.
Good afternoon, everyone, and thank you, Paul, for that nice introduction. We're very happy to have you on our team. Kareth and I really appreciate the opportunity to be here and to tell you about this new study. It's been a long time in coming, as Brian Burke can attest to, and we're really excited to get started on it. And we appreciate the technology that is allowing Kareth to join the symposium. So thank you, IT folks, for making this happen. And I understand that there are other folks around the globe who are watching this live stream as well, so that's very exciting. I've told a few folks here this morning that Kareth and I particularly appreciate technology because she and I have never met in person, even though we've collaborated for over 3 years. So technology has been a real friend for us. So we're in the planning stage of this new project that we'll be talking about. The project is co-funded by the National Institute of Child Health and Human Development and the National Institute of Minority Health and Development. We're in the planning stages, so I want to just start off by saying we're very interested in your questions and in your comments on how that might inform our planning as we go along. So Kareth is actually going to get us started with some background information about the health issues that we're interested in, talk about the scientific motivation for the project, and then I'll talk a little bit more about the aims of the study and what our design looks like and how that maps on to the current AdHealth study. So I'm going to turn things over to Kareth and sort of step aside so she can.
Hi everyone. Thank you so much, Carolyn and Paul, folks at RTI, NIH for funding, and for the larger community of scholars who are participating live in the meeting and also who have logged on to participate in the webinar. It takes a village, and we wouldn't be where we are today with an opportunity to collect data in ad health without the hard work of many, many people over several decades to build the field to where we are today, where we can say that significant disparities have been observed in many areas that warrant a study of this caliber and this investment of resources. And so because we are a diverse group of people who are participating in this discussion today, including folks from around the world who may not yet have a base of understanding or knowledge about LGBT health or issues, we're going to start with some foundational material and then move on to what many of you are probably most interested in, and that is the main course of this new project and what we hope to collect today. So, as many of you know, health disparities have been documented now for almost 2 decades among sexual and gender minorities, with lots learned about what's going on for transgender people and gender nonconforming people in particular over the last decade. Disparities or inequities have been documented in the area of violence victimization, both within families, higher rates of child maltreatment, as well as at school, higher rates of harassment and school-based bullying of lesbian, gay, bisexual, transgender, and gender nonconforming young people. Disparities have long been documented in substance use and misuse, including tobacco, alcohol, and illicit drugs. We see higher rates of mental health issues, including suicidality, particularly for transgender people, where lifetime rates of suicide attempts reach as high as 40%. Rates of HIV/AIDS have been disproportionately high for gay and bisexual men, men who have sex with men, as well as transgender women, particularly transgender women of color and men who have sex with men of color. Barriers to health care, ironically for the groups who need help the most, have also been higher for LGBT people, and that includes experiences of discrimination within healthcare settings, lower access to health insurance, and poor coverage for services that might be needed by LGBT people. So minority stress theory, as many of you know, which is a stress adversity theory that's been around for a long time, but was popularized by Alon Meyer, and then I think really sort of skyrocketed when it was included in the 2011 IOM report on LGBT health, is widely used to understand sexual minority health inequities, and now has been broadened to try to think about transgender health inequities as well. And I think really sort of got expanded when Mark Hassenbuehler wrote a wonderful paper in 2009 about psychological mediators of minority stress. And so this is my simplified version of the minority stress framework that we think has really brought a lot to the field, and we think can be perhaps further expanded to understand the landscape of inequity that we are observing in sexual and gender minority health. And so the general idea is that people are exposed to stress, and that in general, people are exposed to general sorts of stressors, difficulty with bosses and work-life family balance issues, and occasional adverse events that are sort of evenly distributed in the population, but that sexual and gender minorities are also exposed to minority-specific stressors like discrimination, violence, and rejection, and that this disproportionate burden ends up generating higher rates of psychological distress, which are mediated through pathways of emotion dysregulation, internalized stigma, and social isolation, and may be mitigated or offset somewhat by coping and other types of support mechanisms. And so there has been a lot of evidence in support of this particular theory, and while minority stress theory doesn't say that economic pathways are unimportant, economic pathways have not yet been explicitly incorporated into this framework, which we think would be beneficial as far as understanding how to reduce the inequities that we observe in the field. And so this is why we are focusing on socioeconomic status, because we have known for decades, both due to research here in the US and lots of work conducted in the United Kingdom in particular, that socioeconomic factors are fundamental contributors to health across the life course. And of course, fundamental causes comes from the work of Lincoln Fallon at Columbia, and has really been supported through work conducted by National Center for Health Statistics. PAMIC in 1998 did this wonderful SES chart book. And so we see that within the United States that health tends to follow a gradient where people with more education tend to have better health outcomes, people with less education, fewer economic resources tend to have poor health outcomes. We know in the general population literature that inadequate material resources are stressors that are associated with increased risk for depression and anxiety. And so it follows that if socioeconomic status is lower on average among many segments of the LGBT population, that it would, and if LGBT people are at increased risk of discriminatory experiences like discrimination in employment, for example, that LGBT people would be at greater risk of stress through both psychological and socioeconomic pathways. And so there are, of course, gaps in many areas, including knowledge about processes that affect access to resources and strains in general in the general population, but also in particular among LGBT people. So socioeconomic status, if you're a social epidemiologist, seems surprisingly understudied, given its profound associations with health outcomes. As I alluded to before, sexual and gender minorities, on average, have less education. That's particularly true for bisexually identified people in the United States. Have higher rates of unemployment and poverty. That is particularly true for bisexual people, for other sexual minority women, for transgender people, and for men and women in same-sex households raising children, particularly folks of color. Lower earnings have been observed among LGBT people, including among gay men who on average have higher rates of educational attainment but lower earnings, which suggests wage differentials or some discrimination perhaps in wages. Lower rates of home ownership are beginning to be observed among LGBT people. This shouldn't be surprising, but if you don't ask questions, then you don't understand what the full landscape may be of a situation for any particular group. And also higher rates of homelessness have been observed, particularly among youth. We've observed this in the YRBS, thanks to a great paper by Heather Corliss, and also in the U.S. Transgender Survey, thanks to the great work of National Center for Transgender Equality, which has done some amazing work in the transgender arena for the last decade or so. And so the next slide, we'll see some findings from AdHealth, a project that Carolyn and I and Shoshana Goldberg are working on. And what you'll notice here, these are economic outcomes and odds ratios presented here as point estimates with confidence intervals, that among women, women are more likely to be overrepresented in the lower levels of economic status. They are more likely to be poor or near poor in the less than 100% or 100 to 200% of the poverty to income needs ratio. Sexual minority women, and these include women who identify as lesbian, bisexual, or mostly heterosexual, and also report a lifetime female same-sex partner, are also more likely to say that they received public assistance at the last interview, experienced any economic hardship, which includes food insecurity, and were less likely to be homeowners. In the columns that represent findings for sexual minority males, defined similarly in comparison to complete heterosexuals and mostly heterosexuals who reported opposite sex partners only, they were more likely to report lower rates of home ownership. And what you don't see on this particular slide is that they were also more likely to report lower personal incomes than their majority male counterparts. But once you start taking household resources into account, there seems to be a benefit to being a two-male wage earner household as compared to a male-female or two female wage earner households. And another part of the story that we're not seeing for sexual minority males here is that once you take education into account, and rates of college degree completion in that house are higher for sexual minority men in the sample, we see that they are more likely to report economic strain, economic hardship, and this, we believe, is, again, just due to lower rates of returns on education for sexual minority men than we may see for their majority counterparts. So what's going on here? What are the potential determinants of these observed inequities? Well, discrimination in employment seems like a likely candidate. We have not seen population-based discrimination data in a long time. Wow, it's been quite some time since Conron and Mays published from the MIDAS data and observed a fourfold increase in lifetime experiences of employment discrimination among sexual minorities compared to their heterosexual counterparts. There has been some good work on discrimination among sexual minorities and among transgender folks, but not in relation to a general population majority group comparison, particularly in a probability sampling venue. So I think there are some real opportunities here with our new ancillary project. Interestingly, only 22 states currently prohibit employment discrimination on the basis of sexual orientation and gender identity. And so there may be some real policy levers to pull depending on what is observed in the data through the collection of more new data about discrimination experiences. Strained family relationships may be another possible determinant of these observed economic inequities. 20% of resources are transmitted, personal assets, economic resources are transmitted through interpersonal, intergenerational relationships. And so from parent to child, 20% of our assets are attributed to the things that we acquire from our parents. There's been a lot of research supporting evidence of strained family relationships for sexual and gender minority people, even in the absence of abuse, lower rates of support, and less parent-child closeness. And so this may have implications for parental support of education and training expenses, access to health insurance, co-signing of loans for apartments and other resources that people may need. It may also have implications for whether or not families are supporting marriage ceremonies for their LGBT children, which can be a source of cash accrual, and then leading to down payments for housing, which may contribute to lower rates of home ownership. So at this point, there's evidence to support these hypotheses, but not yet data to confirm or refute these hypotheses. So it's an exciting opportunity to be able to collect new information. Until recently, June 2015, same-sex couples did not have the right to marry across the United States. Why does marriage matter? Well, it helps facilitate access to mortgage loans as well as health insurance for couples. Lifetime costs related to health insurance, or the lack of it, is estimated at between $29,000 and over $200,000, particularly among same-sex couples who didn't have access to marriage. We know in the general population literature that medical expenses related to lack of insurance or under coverage are significant contributors to bankruptcy. So we would expect these policies will give rise to conditions that would generate economic inequities. So what else is on the list? Differential costs for family formation. Folks who are in opposite-sex partnerships often have access to donor sperm and assisted insemination services. That is not true for women in same-sex couples in most states, most if not all states. People who don't have a uterus available, who may be exploring adoption, may find that their expenses reach as much as $40,000 to process adoptions, and of course, costs for surrogacy far exceed that. And lastly, another possible contributor to the pattern of health inequities, health and economic inequities that we've observed among LGBT people are out-of-pocket expenses for gender-affirming health services that are not covered by insurers. And these include things like gamete banking for folks who want to preserve their fertility before they initiate hormone use, as well as chest surgeries, augmentation or reduction, and facial feminization, other things that may be very important for people to live authentically, which is important for psychological well-being, as well as also to be able to exist in the world free of harassment and violence. And so it's no small thing for someone to be able to access gender-affirming health services. And lastly, of course, there always has to be a solution posed by any project that we do for a particular problem. There are lots of great data sets out there. Not very many of them collect SOGI information, sexual orientation, gender identity information. In particular, some of our most important sources of information about economic status and economic determinants in the United States are operated by the U.S. Census Bureau, things like the American Community Survey, the Current Population Survey, Survey of Income and Program Participation. They don't include measures of sexual orientation and gender identity. They do help us identify same and other sex households, and that's really important and useful, but what we miss are people who are not currently cohabitating, and of course the many sexual and gender minority people who are not living in same-sex households. And there are, of course, lots of great cross-sectional studies, particularly in the public health arena, that do collect information about sexual orientation identity, and an increasing number are beginning to add measures of gender identity, assigned sex at birth, or transgender status. But these surveys tend to collect lots of great information about health and not a whole lot about socioeconomic status outside of current educational attainment and household income. These surveys also are not designed to collect information about formative developmental experiences and milestones, particularly of sexual and gender minorities, nor are they designed to collect a lot of information about family relationships. So, and of course, we have some really great longitudinal studies of sexual and gender minorities here in the U.S., but they're small community samples, and then our large cross-sectional representative samples are great, but they're Gen Pop samples, and they often don't have some of the data that we need. So enter Add Health, longitudinal and population-based, with already some great information available about sexual minorities. Of course, Carolyn will talk more about it, and increasingly will provide more information about gender minorities. So at this moment, I turn the microphone back to my dear colleague, Carolyn, and thank you so much for listening and participating in this discussion today.
To address some of the data problems, we decided that we would try to capitalize on the Ad Health design and history to address that. And so what I'm going to do is provide a little bit of background about Ad Health and its design. I've listed the principal directors, principal investigators and directors for the first wave, which was first and to third wave was J. Richard Udry, and now Kathleen Mullen-Harris is the current PI of Ad Health. So I'm going to explain some of our project goals and how we plan to build on the Ad Health data resource. So Ad Health is started as a school-based study in 1994. The overall goal of the study was to learn about the life experiences and the social and physical contexts in which adolescents lived, and to understand how that affects their health and their risk behaviors, and then how those adolescent experiences may affect health going into adulthood. So this slide which I'm not going to go through in detail, shows the complex sampling structure of a study. I just want to point out that, originally there were about 90,000 adolescents who completed an in-school survey. And after that point, about 20,000 adolescents were selected for more in-depth in-home surveys. And that's the key sample that we've been following since 1994. Okay, so this slide shows the longitudinal design of AdHealth. And as you can see on the left, there have been 4 waves of in-home interviews completed to date. We've had, thanks to RTI efforts, we've had very great, strong sample retention as we've gone through these different waves. On the right, you can see the participant ages at each of the waves, and you can see the number of participants that we've had at each wave. So data collection is currently ongoing for wave 5. We're targeting more than 19,000 eligible AdHealth respondents for wave 5. As was mentioned by Paul, RTI has conducted the field work for AdHealth beginning in wave 3 and going forward. And Brian Burke, who's here, has been the project director on the RTI side since wave 3. And happily for us, he's also going to be the project director at RTI for this new study. So we're capitalizing on wave 5 and the resources that RTI has put into place as far as structure and tracking and so forth. But AdHealth wave 5 is really complicated, and Kathleen and Brian can both speak to that. It's very different from the earlier waves of AdHealth in a lot of ways, and I've tried to just kind of illustrate that here by showing you the sampling design plan on the right there, and then also showing you a photograph of some of the AdHealth team members going through what seems like the gazillion billion mailings that we've sent to our respondents over time. So it's very complicated, lots of moving parts, but the key difference that has relevance for our new study is that in wave 5, AdHealth transitioned to a web-based survey with a paper teleform backup, as opposed to the previous CAPI-CASI in-home survey. So it's a really big change that has permeated through lots of instrumentation issues and so forth. So since we are capitalizing on wave 5, we also are adopting that web-based survey design for our new study. Okay, so why is AdHealth the right study to do this, to try to understand the health disparities among sexual and gender minorities? Well, for one thing, there is a very large and diverse sample that, as Carolyn noted, is population-based. A second factor is that there is a really wide scope of prospectively captured content across a span of more than 20 years. So there are a lot of domains. I've just listed some illustrative examples here, and you can see that for a lot of those things we have repeated measurements over time, and we also have had the opportunity to incorporate new content that becomes developmentally appropriate as people move through their life course. So we've been able to capture new developmental domains and social domains. So for our study in particular, one of the key advantages of AdHealth is that it has about 20,000 sexual minorities who were not selected into the AdHealth sample because of their sexual orientation. It's a large sample, happened to capture about 2,000 sexual minorities. So the great thing that's really distinctive from some of the other work is that this is a population-based sample of sexual minorities. So it's a really key advantage. And it's diverse in terms of socioeconomic status and in terms of race, ethnicity. And we have 20 years of prospectively collected data on this population-based sample. So AdHealth truly is a unique resource for trying to get at some of these persistent health disparities that Carolyn described. All right, so finally, what do we plan to do in our new study? So we have 4 aims. Aim 1, as you might imagine, is to develop a new survey instrument that will capture some new information that is not currently available in AdHealth in order to help us explore the hypotheses that we're testing. We plan to conduct an ancillary study with web and mail, as I mentioned, with all the sexual and gender minorities in the sample and a comparison sample of heterosexuals. Our goal is an 80% recruitment rate for the eligibles. That may be optimistic, but we'll try our best. Our third aim is to prepare data for dissemination to AdHealth users. So AdHealth has always operated under a data sharing plan that when the data are collected and cleaned and ready to use, they're sent out to users, contractual users globally, in order to use the data so the investigators get the data essentially at the same time as other users get the data. So ancillary studies that build on AdHealth are bound to that same data sharing agreement. So in our case, we will be collecting these new data. We'll need to monitor data quality, do the data cleaning. There's always a deductive disclosure analysis to see if you need to fuzz data in some ways. We'll construct a data set and we'll prepare a code book that will be useful for users. And then finally, we want to use life course in the minority stress theory that Carolyn described to conduct some substantive analyses to understand. In our case, for this particular study, we're going to be focusing on mental health outcomes out of that array of health disparities that Carolyn talked about. So this is our conceptual model. You can see that it looks sort of similar to the minority stress model. We are basically hypothesizing that differences in sexual orientation and gender identity can affect parent-child relationships, that quality, and can also affect discrimination experiences. So the direct and the indirect pathways that are depicted here in the model can influence socioeconomic status. And socioeconomic status in adulthood, in turn, would be linked to economic strain and stress, which would heighten the likelihood of depressive symptoms. So it's not shown here in the diagram, but we're also interested in sex and race ethnicity differences in this model and how these processes may play out differently for different groups. So our sampling plan is to try to interview all the sexual minorities that were identified, self-identified at Wave 4, and any newly identified minorities in Wave 5. And on the slide here, I've listed the categories that are in the survey instrument that reflect a sexual minority category. We also hope to identify transgender respondents at Wave 5 and to include all those in our sample. And we will collect data from a random comparison sample of 1,500 cisgender heterosexual respondents. So if we are successful in our 80% response rate, we should end up with just shy of 3,000 or so respondents with longitudinal data. But one of the cool things that we're doing, I mentioned we're in the planning stage right now, and we've been talking with Dr. Beamer and with Dr. Suchindran at UNC about revisiting our thought about the sampling plan and thinking about an innovative way to identify appropriate respondents to participate in the study. So rather than relying on a single self-report of orientation, identity, we plan to do something a little more creative, I think. And because as you can imagine, if you looking over 20 years, we have multiple measurements of attraction to same and opposite sex and identity in terms of sexual orientation. And for some respondents, they are not consistent over time. There's some fluidity there that is partly, or hopefully largely, a developmental change as people are growing up. So this is an opportunity to capitalize on the longitudinal data that we have and the repeated measurements that we have to try to identify respondents who are likely asexual minorities. So, for example, we can do a latent class analysis, and maybe there will be some respondents where it's highly probable that they're sexual minorities based on these different pieces of information that we've pulled together, or it's highly probable that they're heterosexual. And we imagine that there's going to be probably at least one other class where it may not be as obvious, what the classification ought to be. So we're excited about this. I think it's an innovative approach to identifying minorities, and I look forward to our findings with that. In terms of survey content, I mentioned that AdHealth already has a lot of content that is relevant for our study, which is one of the reasons why we think it's the right study to do. There's information about quality of parental relationships. There are socioeconomic indicators, indicators of sexual orientation over time, stress, mental health, and life course events. And new to Wave 5, which is also exciting, is we have, for the first time, have a question in AdHealth about gender identity and gender expression and assigned sex at birth. And this is the way by which we will identify transgendered respondents in the AdHealth study. So AdHealth is a rich data set, but not everything is there, of course, that we need, and that's why we're doing this study. So we've identified some key domains that we need to use to flesh out information about our respondents. One, as Carith mentioned, is the timing of identity milestones, which we have no information about that other than what they report over time in terms of identity. We would like to get more information about gender expression over the life course. And we'd like to supplement the information that we have about parent-child relationship qualities with new information about acceptance and rejection and intergenerational economic transfers that Carith mentioned. And finally, of course, economic supports and strains. So where are we now? We are actively trying to hire a project manager. I'm interviewing the first person this afternoon, so I'm very excited. We're trying to work on our sampling plan and get that finalized. We have started to work on the survey instrument to identify the content and the kinds of questions that we want to use. We have set ourselves a very ambitious goal of trying to get into the field. I see Kathleen going, ah! A very ambitious goal of trying to get into the field in September. I don't know if we'll make that, but we decided we would give it a try. If we do make that, or sometime fairly close to that, we hope that we would be able to release data to AdHealth users sometime in early 2021, which is kind of weird to think about that it's that far out, but so to kind of sum up here, our goal here really with this new project is to develop a new and unique multi-level intergenerational data resource that users around the globe can use to try to understand the contributors to health disparities among sexual and gender minorities. We're hoping that if we, and I'm sure we will, produce high quality data, and that those data will allow us to improve our understanding of health inequities. And, in a right world, those findings would be informing policy and programs that could be used to divert negative trajectories and try to foster healthy development. So thank you very much for listening, and we wanted to make sure that we had plenty of time for questions and comments because, as I said, we are in the planning stage, and we'd love to hear any suggestions that you have, or happy to answer any questions that you have. So thank you. I guess so.
Okay. So you mentioned at the very end around the globe, and it triggered two thoughts. One is, are there data sets for cohorts that are outside the U.S. That would be informing your survey questionnaire development? item comparisons, so you could compare to other data sets. And the other piece is, to what extent do you hypothesize cultural aspects within a given country? I mean, obviously the norms are changing here in the U.S. I imagine outside the U.S. there's different contexts.
Yeah, one comment is I may have misspoke when I say around the globe in terms of AdHealth. I mean in terms of users.
Users, right.
Not in terms of participants. All our participants are U.S. Kareth, can you speak to, I don't think there are any data sets that are anywhere close to AdHealth in other countries in terms of the diversity of content, but Kareth, maybe you'd like to comment on that.
There are not, to my knowledge. There are measures of sexual orientation and moving to measures of gender identity in cross-sectional population-based surveys in other countries, particularly in Western Europe. There are sometimes better measures of SOGI in health service system environments like electronic medical records in other countries, but by and large, I would say the United States has really kind of been the leader in LGBT health research, and so it's often measures that we have developed and used here in the U.S. that inform the kinds of at least demographic measures, and actually even other kinds of measures too, that people are using in other countries after doing cross-cultural validation checks. So I feel like we have a lot of great information and measures to draw from here in the U.S.
Kareth is our measurement expert. Did we answer all your questions, Tim?
Yeah.
Okay.
Yeah. It was US-based.
Mm-hmm. Mm-hmm.
Thanks for a great talk, Carolyn, both of you actually, and Kareth. This is really important. I'm really glad it's being done. I think we've talked about needing to develop more instrumentation. So I think I have a comment and a question.
Okay.
One is, I think we know with latent class analysis, unfortunately, it's a great way to do classification, but it also, you lose data, the sensitivity of the data. So if we think of heterosexual or we think of more homosexual, bisexual, gay, we think of gender identity, it's a spectrum. And I love the questions you have, but what happens with latent class analysis is that people do get grouped in classification, we lose the sensitivity. Mm-hmm. And I would worry that you don't have that spectrum when we try to be more sensitive about what is somebody when they say, well, I may be in the gender spectrum. So and that's where we're trying to be more sensitive about what am I? And what is that, especially when we think of the stigmatization of classifying people. So that's just my comment about that, having done some of that. The other one that I wanted to ask about is in your modeling, I think some of the criticisms we've had when we talk about individual versus family, when we talk about social ecological, individual relational, we don't do enough about structural. And so you may have, education, you may have employment, but we really do need to understand more, and I might suggest this, even when we think about what's going on in the world, and we saw the stuff with Oprah just recently, and we talk about the white world versus the black world, we're not talking enough about the structural stuff that keeps people down. There's some lucky people. Oprah got lucky. She came from the poor Mississippi. But how many people have been oppressed? How many people feel stigmatized and can't speak? And it's not just within the family, but it's also within the structure, or in their business, or in their work environment, or in their profession. So I just think that needs to be maybe stretched or explored a little bit more.
Yeah, thank you for those comments. I'll say a couple of things and then see if Kareth may want to add something and Paul may want to add something. Thinking about the latent class analysis, we haven't done it yet, so we don't know how many classes we're going to get. And I imagine that there probably are going to be, that there will be this spectrum where, maybe that one class that I talked about where it's not clear which category someone ought to go into, maybe that's really going to be 4 classes. We just don't know yet. So I think we can maybe because we have so much data, I think we might be able to do a better job of trying to capture that spectrum that would be the case if people only have a measure about self-reported identity. And the same thing with gender expression, that we have different ways to try to get at that as well. So it points to another reason I think why AdHealth is such a helpful data set to use for these questions. And then in terms of structural factors, AdHealth has incredible structural information about the environments that people have lived in since they were adolescents. So there's a lot of contextual data that's been attached to the survey data, and you can get a sense of what kinds of neighborhoods people are living in different times of their lives. We have questions about problems on the job, questions about perceived discrimination. So happily, there's a lot of information that we can use to triangulate on some of these key issues that you've brought up, Wendy. And Kara, would you like to add anything?
Yes, just sort of reiterating that there's a measure of microaggressions, everyday discrimination, Williams measure, on the Wave 5 survey, which gets at when you feel that people are acting in a way that is disrespectful or undermining of your dignity, which is a really important aspect of discrimination, and that we will be collecting information about major life event discrimination, discrimination in employment and housing and education, as well as questions that I think suggest, inequities in coverage around health insurance services that impact people's well-being, and also if you believe that in a health and you believe in a human rights framework, the right to parent and to have families is considered a human right that here in the United States, I don't think our health insurance system really reflects or supports, but we will be able, I think, to get some data to inform those discussions and to inform many policy-oriented discussions related to structural factors that we collect through this survey and in partnership and conjunction with previously collected AdHealth data, which is really about understanding the impact of stigma and its manifestations on sexual orientation, gender identity experiences within the population. Carolyn, there's a question that came up on in the chat, and I'm not sure if I should read it aloud or if someone from RTI will, or if you can see it.
Maybe I missed something, but Wave 5 is of people who are currently adolescents, is that correct?
No, sorry.
Oh, I missed that. Okay.
Okay.
So I was like, well, then their income is just their parents' income, which doesn't help with this. So they are not
Yeah,
currently.
they're in their 30s and
Oh,
early
they're like
40s.
Okay, never mind.
And that's the great thing. I mean, we can look over that span of time.
Hi. I was wondering if you've considered looking at the children of these participants, because I think I saw that the parents were interviewed, and I think it would be really interesting to look at, maybe not in this data collection, but a further data collection to look at the children and see what their thoughts about having parents in this situation would be.
Yeah, that's a great question. Our Kathy Harris and my fantasy is that some young, industrious investigator will want to take on the challenge of doing a children of ad health study. There are, thousands of children and of various ages, so it's, it's a really great opportunity for someone to really do a major intergenerational kind of study. So, but it won't be me.
We do have one online question. For the racial ethnic minority groups, will those with small sample sizes be oversampled? Most LGBTQ data sets do not have sufficient numbers of racial ethnic minorities.
There, in the original and ad health sampling design, there was oversampling of a variety of different racial groups. Because we're not exactly sure what our sample is going to look like yet, we haven't taken the next step to look at, a cross-tabulation of race, ethnicity with whatever indicator we end up using for sexual minority status. I suspect it will be an issue. It always is, even when you have 2,000 people. When you start slicing and dicing, you get very small sample sizes. So I'm sure it's a challenge that we'll have to struggle with. But I think we're, because it is a reasonably large sample, I think we'll be in better shape than some other studies have been in.
Thank you so much for your time. This is really exciting to see that this study is going to be rolling out and we're going to be getting such rich information. My name is Katie Grimes. I lead the LGBT plus Rising working group of the Global Gender Center. And our goal is to connect RTI employees across the Institute that have an interest or previous experience working with LGBT populations and to add to the research base and also programs working with LGBT populations. And I was really happy to see the whole suite of indicators that you're interested in including in Wave 5, getting at a lot more of those nuances for sexual orientation and gender identity, including the relationship that participants have had with their parents. And I understand that the Williams Institute does have some really good guidance on SOGI questions and survey research, but I'm curious where the source material is coming from, all of those other indicators that I saw up on that slide, whether you're working on creating those yourself or if there are already measures out there that you'll be using.
So the one slide that shows different content over time, those are measures that have been included in Ad Health since the beginning or added on down the road. They come from a variety of different sources. Some come from standardized instruments. Some were developed explicitly for Ad Health. So they the sources are diverse. In terms of what new measures that we'll add to this ancillary study, again, Kareth is our measurement expert on that, and as you know, the Williams Institute is a leader in developing measures and thinking about these kinds of issues. So, Kareth, maybe you would like to add some comments to that.
Sure. So many of us here are PhD level social scientists, so when we design our surveys, we look for measures that people have used and have provided information about psychometric properties for. Often when we measure discrimination, we start with at least a version of Williams' major life event discrimination measure, and sometimes we adapt it a little bit, or maybe we could look at the measure discrimination from the MIDA survey in terms of understanding gender expression as it's changed over the life course. Most of us use Zuckerman's Recall Childhood Gender Nonconformity Scale, and then also I've been involved in testing and modifying the socially assigned gender nonconformity measure that is the gender expression measure that people are generally using, that Gina's recommended and Bryn Austin and Sarah Wiley and Heather Corliss did a lot of work on. We adapted it to be context-specific for use on the YRBS survey, and did some cognitive testing there. So we, in doing survey construction, try to use measures with known psychometrics. When we can't do that, we go to other large population surveys to at least identify items that are comparable. And so Survey of Income and Program Participation, National Longitudinal Survey of Youth, the Medical Expenditure Panel Survey, National Survey of Family Growth. These are places that we would look for items to pull together into our survey because, of course, everybody wants data that are comparable to other sources where possible. And, of course, when you don't have good measures available, you end up having to create them yourself. That's how we have lots of measures of SOGI that are now on surveys all over the place. And where we can, we do cognitive testing of those items. And fortunately, we have some budget and resources to partner with RTI to make sure that any new measures that we develop for this project in the survey at least go through some sort of testing before we expend vast resources using them to collect data.
Met in person before, and the way we got together was I wanted to include some measures of gender identity and expression on Wave 5, the main survey, and so she's the person that I turned to.
This is fantastic. You know, forget the HHS funding environment and whether we're going to work in 7-8 days and all those things. But thinking about the 70,000 that didn't make from the 90,000 down to the 20,000 that were in the longitudinal study, have you ever thought about going back to those 70,000 and trying to get key variables for comparisons, given the fact of what's, and you might have, I just don't know.
Yeah, I actually don't think that's possible. I don't know, Brian, if you know. I don't know that the identity information for Ad Health is stored outside of the U.S. For complete protection, and I'm actually not sure if anything more than those 20,000 that did the in-home interviews. I don't think that we have that information anymore for that 90,000.
Always worth a shot.
Yeah, and it does seem like a location nightmare. So
We do have one more question from online as well. For American Indians, what is your plan to categorizing Two-Spirit as it has been described as both gender and sexual ID?
I'm as far removed as anybody in these kind of studies and things, so this will be maybe a very naive question. But I grew up, like lots of people, you can tell by my age, where this was not very well publicized at all, and certainly I played sport. I never knew anybody that was even considered in this area, and certainly kept up with professionals and everything. As you know, that's changed. You have people that highly, recognized, well respected, that now are in these categories. Will is the studies going to take? Is there potentially differences? Anything that's about this?
as far as
Anything? I say I have no idea. I just know that it's something, and I think in my view, I think it's changed people's attitudes tremendously.
I'm not quite sure what you're asking. Are you asking whether we have information about how public attitudes have
Will
changed?
your studies reveal anything in regards to this?
We don't have measures of that. I know there probably are surveys out there. Pew probably does a survey, but Ad Health can't address that. I don't know, Kareth, if you would like to respond to that.
Sure. So I think collecting attitudinal data would be beyond the scope of this particular project, but in addition to Pew, there's a group called PRRI that does some really wonderful public opinion polling research on attitudes towards lots of things, particularly related to religion and culture, but also attitudes towards LGBT people and rights and discrimination. And they have a wonderful website with great visualizations of their data that I would encourage you to look at. There's also been some good work recently by the Harvard School of Public Health and NPR on discrimination against LGBT people, with some information about attitudes there. And the last source of information about attitudinal data is the General Social Survey, which has been collecting information about attitudes towards sexual minorities and for quite some time. So hopefully those will be some good resources for you.
Is there one more question?
There is one online. For American Indians, what is your plan for categorizing Two-Spirit as it has been described as both gender and sexual ID?
There are American Indians in the AdHealth sample. It's still relatively small, so I really don't know that we're going to be able to address that in a very effective way. It's not clear how many American Indians will end up in our sample, but it's even in the larger 20,000 AdHealth sample. It's a fairly small number, although bigger than most studies, but still fairly small.
And this is Kara. The gender identity question has an opportunity for a write-in response. And so if we're able to classify people as minorities, it would be as gender minorities under the particular survey construction.